So, I I'm Brendan Gould. I was going to say I'm Honor Guardianship, but I'm not. It feels that way sometimes, right? So, Guardianship Services was a company that I started in 2010 with my wife, and just a presentation overview here. We're going to talk about treatment guardianship and the timeline as to when we started and how things have progressed. We're going to talk about family versus corporate treatment guardianship, how to obtain a treatment guardian, benefits of a treatment guardian, obstacles, and there are several, and advocating, and how to contact us. So, about treatment guardianship in general, New Mexico Mental Health Care Treatment Decisions Article, the law 24-7B1 has provisions which allow for the appointment of a treatment guardian when a person lacks capacity to provide informed consent for psychiatric treatment. So, in other words, if let's just I don't want to just read from the screen, so let me just take a little step back here. So um we become the treatment guardian when there's a qualified healthcare professional that is going to say on the record that the person lacks capacity. And what that means is that the severity of their mental illness is so severe that they can't make decisions for themselves surrounding or involving their mental health treatment. Okay. So the reason I say that specifically is because there are two different kinds of guardianship. There's treatment guardianship, and then there's also what's called plenary guardianship or full guardianship. And treatment guardianship is specifically there's somebody coming in. The way I usually do presentations, by the way, is just very organic and flowing. If you guys have questions, interrupt me. I'd like to be this more of like a conversation. Okay, so I'm gonna go here roughly by the outline that I had someone make for me, but I really do want this to be more of a discussion. Okay, so feel free to interrupt me. Don't worry about interrupting me. It's totally fine. So the reason I think that, and I had some, I have this young woman that works here, and she builds these presentations for me. And usually because she's younger, she makes things, she kind of has this kind of 80s spin on everything. And I told her, no, I want everything black and white minimalist. So I think she did a pretty good job. This is about as minimalist as it comes, right? So I really owe her one. This would have taken me 6 hours to do. Like, it took her a half an hour. So she's just so impressive. So anyway, there's that big difference, okay, between probate code or plenary guardianship and treatment guardianship. Treatment guardianship is very specific, and it's only over psychiatric or mental health decisions. They retain, the client patient retains the capacity to make decisions in all other regard, as far as like financial, where they live, medical, they retain those rights under treatment guardianship. The only rights they don't retain are making mental health decisions. Okay, so it's a very limited form of guardianship. The treatment guardian is appointed through the local district court. There must be a qualified healthcare professional, i.e. doctor, social worker, sometimes nurse practitioner can serve, but they have to testify in court that the person lacks capacity. Okay. The other interesting part about treatment guardianship is that it's very limited in scope and in time. Plenary or full guardian, it's forever until the judge decides differently. But in treatment guardianship, it can't go over more than 1 year. So after 1 year, it's automatically it's terminated. Okay, it can go shorter than a year, but never longer, and that's part of the law. We make decisions about psychiatric treatment for a person unable to provide informed consent, like we had just gone over. Maybe I should stick to the slide a little bit, right? This is kind of the general timeline for Honor Guardianship Services, and it's just so funny to see 12 years to 13 years of work like compressed into a little slide like this. But so in 2010, my wife and I, Maria Gould, we opened Honor Guardianship Services, and we began the treatment guardianship. I went to a hearing at UNM Hospital Mental Health because I was very curious about it. And I think this is true, but a lot of people within NAMI are there for family members, not just themselves generally. But I had a family member, a close family member that was severely mentally ill. And so I've always been interested in this field, but also the stigma of mental illness doesn't scare me because I grew up with it. So it was normal. And a lot of people, I think, stray from this field or stay away from this field because of the stigma and the fear that comes along with mental illness. But if you grow up with it, there's nothing to be afraid of. So anyway, that's what sparked my interest in this. My father suffered greatly. So in 2013, I saw a court hearing, and I thought, I got to figure out a way to get involved with this. So we put in a request for proposal with the state, and we won a small contract to serve Bernalillo County. And the reason that this is significant is because the other people that won a request for proposal to do this program, they quit. So I got a phone call from a state agency basically saying no one is willing to do this in northern New Mexico, meaning Santa Fe, Las Vegas. And me being 31 at the time, I was like, yeah, sure, I'll do it. Great. I have lots of energy. So we started doing that in 2014. And then the southern part of the state, there was an agency, and the person that ran that agency, it was called FICDAC, passed away. And there was no one there to fill the gap in southern New Mexico to do treatment guardianship. So I said, of course, I'll figure it out. So we figured that out. And so now, lo and behold, we have the only treatment guardianship company in the state of New Mexico. But that's okay. I mean, we're doing it. We're getting it done. I am not generally the kind of person to let my ego run away with everything and say, no, this is mine. We're constantly looking for people to help. The more the merrier, because as you, I'm sure, all know, there's not a lot of services and help for people with mental illness in the state. So I encourage partnerships whenever I can. So right now we serve about 500 people with mental illness across the state. And we've had to get very creative with our budget, if you understand and can read between the lines. So familial, I didn't write this. I would have never put that word in there. I can't even say it. Familial treatment guardianship. Okay. The guardianship from family is preferential to corporate guardianship. I truly believe this. Okay. And the reason I believe this is because family will never know, or I'm sorry, I will never know about a person as much as a family member. So it's very important to me that all other options are exhausted before our company takes over treatment guardianship. That's very important to me. Now, every once in a while, what I would say is that sometimes family can't do it because of violence, or because if you try to get somebody to get treatment, they resent you for it. So there is a time and place for a corporate guardian, such as Honor Guardianship, but I think that family is the best. And that's for continuity of care purposes and for the preferences, knowing your family member, knowing what their preferences are and what their priorities are in their life. So corporate treatment guardianship can alleviate some pressure put on families. A corporate guardian does not have the same stressors for inter-family relationships. The person that I had write this she's very smart. So look at how she worded this as compared to how I worded it. A corporate guardian does not have the same stressors for inter-family relationships, and they are able to make treatment decisions without the same worry a family member may have of damaging the relationship. Couldn't have said it better, and actually I can't. I got to give her a coffee tomorrow morning. How do you choose? When do you know? When considering either options for treatment guardianship, it is important to consider the pros and cons for each. Any decision made should place the best interest of the person as the highest priority. This is kind of, it seems like a no-brainer, but it's something I have to deal with on a daily basis. A lot of times when we're in this field, it gets very stressful, gets very convoluted, and there's a lot of conflict and politics, believe it or not. And I a lot of times have to get people back to what's important for the patient, what's important for the client. That's our priority. If it upsets somebody, I'm sorry, but that's what we have to do, and that's what we keep in mind. And if you keep the purity there, then the company will do well. And so this is kind of a speech I have to give on a weekly basis to people. But how to choose is what's best for the person. You know, if mom is the treatment guardian, but it's conflict constantly, and the relationship between mom and daughter, let's say, is stressed by this relationship and actually causes more mental illness, then that's not what we want, right? So if we have a third party that can come in and act as mediator, so to speak, it does tend to help in certain situations. And I've been involved in some of those situations because of sometimes there's violence, you know, son is mentally ill, they haven't taken their medication, they're actively psychotic, they're not making good decisions, they scare mom. That's a good situation for us to come in and say, okay, we're a third party, we're going to listen to what you have to say, your mom's just going to be your mom. But every case is different. I don't make blanket statements. I don't paint with a broad brush. I think it's very important that you take each situation individually and make that decision. But we are here as a corporate treatment guardian if that need were to arise. Okay, now the not fun stuff. How do you get a treatment guardian? You got to go through all this stuff. You got to jump through hoops. Consider if a TG is necessary or appropriate, obviously, right? Work with the psychiatrist or provider, because the first thing we're going to need is a person that's a qualified healthcare professional that's willing to testify that the person does not have capacity or informed consent to make their own decisions. Am I talking too fast? Okay, so no. We got to make sure that there's a doctor on board that's willing to testify, because we can't have anybody appointed unless we have that. The reason is because once they get a treatment guardian, they lose civil rights. And I know that this isn't real popular with guardians to talk this way, but I just like to keep it real, okay? The reason being is you're literally losing your rights to make these decisions. And I think we should take that very seriously. So there needs to be a judge, there needs to be a qualified health care professional to testify, and then those rights can be restricted, okay? What did she write here? Work with treatings, yeah. Consider the person's psychiatric history. Okay, that's also part of it too. Do they have a history of not taking their medications, going off their medications? You guys are in NAMI, I'm sure you know, a lot of times with people with mental illness, they start taking their medications. I feel fine, everything's going great. I don't need these medications. And then everything regresses. All right, and then we got to try to get back on the medications. That for me is just, I've seen it a lot, and it's hard because you're trying to describe that to the person with severe mental illness, and when they're on their medications, they're totally able to rationalize that, right? But once they're off their medications and they start to slide, then it's hard to be rational. So we need somebody to testify sometimes, look, he's got a history of not being in compliant. I hate that phrase, but it's used all the time. They're not in compliant with their medications. They need a treatment guardian to make sure they stay on track. That is a totally legitimate reason. It's something that needs to be weighed, I guess I should say, in whether or not somebody needs a treatment guardian, okay? The next part is, and we've had to become kind of pseudo lawyers, right? Because when we started this program, and I'm by no means a rich man today, but when we started the program, we had absolutely no money. And we had to figure out a way to make the court system work for us. So we kind of trailblazed a little bit. We found out how to petition the courts, how all of that is done, and you can do it. You don't have to be a lawyer to petition the courts. Okay. So you petition the court and they have to give you a hearing. And but you got to remember there are different kinds of court. There's district court and there's metropolitan. Okay. And there's federal, but the one we have to go to petition is district court, whatever county you're in. Okay. Requirements vary from county to county. This is a big issue with me because it should be the same in every county you go to. It really should. It's one state law, but every county does it differently. This is something I've been working on for a long time. I've made some headway, but not much. Every county, I think, should do it the same way. Okay. But I don't know if most people here are from Santa Fe, but in Santa Fe, the district court, you would go down and petition, and it's done similarly to how it's done in Bernalillo County. So you would petition, but you got to make sure that there's a qualified healthcare professional that can attend the hearing. You also have to make sure that your loved one or whomever you're doing this for is also going to be at the hearing. So the reason that gets quite complicated, it's hard to deal with all the logistics involved. And that's why you'll see, if I had to put a number on it, 99% of all treatment guardianships are done while the person is hospitalized. Because if they're hospitalized inpatient, that means that the qualified healthcare professional is right there for them to testify. And then the the hospital uses their lawyers to petition the court. So everything is set up for them. So that's, I would say 99% of all treatment guardianships are done while the person is hospitalized, committed. Okay. Attend hearing and begin working with TG. Notify any treating psychiatrist provider of the appointment of the treatment guardian. This is important because the person no longer has they no longer have the ability to make decisions on their own. So we've got to notify the prescriber. We've got to notify the prescriber that this person no longer has the ability to make these decisions. Okay. Oh, benefits to treatment guardianship. I'm sure there's a couple. So the very reason the person with a mental illness, because they're incapacity, they're probably not going to be able to advocate for themselves. It's going to be very challenging. People will have a hard time. People will have a hard time hearing them because of the symptoms of the mental illness. So as a third party, a professional advocate, you're going to be able to be heard. The communication is going to be a lot more clear. And that kind of segues right into what she put here: bridge communication between patient and provider. Okay. So in other words, it's kind of like, and a lot of guardians don't like to use this verbiage, but it's what I use. So, but we're basically a surrogate family member. Okay. We're here to take the interest of the client first and advocate for them to their provider of what they need. Are they having side effects? Okay. I always use this story because it really happened, but it's also very poignant. One of the first treatment guardianship clients I had was in jail, and she was refusing to take her medications. And I got to know her, we became friendly, and finally she opened up to me and told me the reason she doesn't want to take the medications is because it makes her gain weight. And she's a professional exotic dancer. So she was a stripper. So if she gained a lot of weight, she wouldn't be able to do her job. And once I found that out, we talked to the psychiatrist and we found some medications that didn't have the side effect of weight gain. And she started taking her medications. So there we are, we're bridging the gap between the provider and the client in order to get their treatment the way we need it to be done. It doesn't disrupt her life anymore. Okay. The other reason is because the benefit, I guess I should say, is that having a third party that's objective can notice side effects. So if we're seeing some tardive dyskinesia or some involuntary movement with the jaws or rigidity in the arms, we'll be able to notify the prescriber to say, look, this isn't working out. What can we do? You know, the side effects are detrimental to the person's life, such as weight gain. If you're a professional exotic dancer, it might disrupt your career. We've got to seriously consider those things. Ability to petition for an enforcement order. Has anybody ever heard of an enforcement order? No. Okay, so an enforcement order is unique to treatment guardianship. Part of the law is we can seek an enforcement order, and then we send all the information to the judge about enforcing treatment, and the judge can weigh in on whether or not to sign off on the forced treatment. This is controversial. I call it the nuclear option. We don't do this unless we absolutely have to, because it can be traumatic and it can be very difficult for somebody with mental illness to have to be picked up from the police to be taken to the hospital for forced treatment. All right, we do not want to do this. This is what we do when we don't know what else to do and the person is refusing to cooperate. I like cooperate better than compliance. So we want people to cooperate. Okay. I think it might be on another slide, but I'm going to say it anyway. What I tell people is if you're a good treatment guardian, then your client is going to be calling you and asking you for advice. We want the person to know that we are not an authority figure that is going to be punitive or is going to assert our authority in a way that's going to make the person feel uncomfortable. We want to be able to gain their trust. We want the person to be able to come to us and say, look, I'm struggling with this. You know, I'm taking this medication for my manic episodes, and I'm bipolar, but now I'm feeling severely depressed. And Brendan, I'm just not sure what to do because of the depression. Do you have any ideas? And the reason I use that example is because it happened to me about 3 hours ago. This young man came to me and said that. And I thought, okay, I'm doing my job well because he's coming to me and asking me for help. So as a treatment guardian, that's what we want. That's the goal. Okay. Now the hard part, the part I hate talking about, all the obstacles. Boy, poverty-stricken state, not a lot of services for people with mental illness here, is there? No, there's not. It's a sad state of affairs. And hopefully over many years of hard work, we can help with this. A lot of times, number one thing we see is hospitals will say, well, you're the treatment guardian. You can sign off on a person receiving a medical surgery, right? A procedure. And we say, no, treatment guardian doesn't mean medical. It means psychiatric. So the first thing I teach people that become treatment guardians is you have to have a real firm boundary with people and say, I don't have authority over that. I only have authority over their psychiatric care. So I can sign off on them getting therapy. I can consent to treatment through medications, ECT, what have you. But if you come to me about a surgical procedure, I can't help you. They still retain those rights. And so that's very important for people to know about treatment guardianship. The other obstacle in this one's hard, substance abuse. A lot of people with severe mental illness will go out and self-medicate, and then they become addicted. And in turn, it exacerbates their severe mental illness. So this one is like, I think methamphetamines is the devil. Okay. People with a case of bipolar disorder, but they're able to manage it. The medications are working. The minute they do methamphetamines, all bets are off. So I hate this stuff. It's a real obstacle because it's so addictive, and the way that it works, it exacerbates the mental illness and it causes havoc. And it's very difficult to tell people how bad this is for them when they feel so good while taking it. I had a client that said, look, I can find meth for $8 and be high for 24 hours straight, or I can be miserable in my my boarding home room sober. And I was like, well, that's not real optimistic or favorable outcome there. The methamphetamines is going to win. So this is a big deal to me. I'm not really sure how to combat it. It's a huge obstacle for us. Next, lack of knowledge from providers about treatment guardianship. A lot of people think I can just snap my fingers and say, you're taking your medications. Or I can say, this is where you're going to live. I can't do any of those things. I can try to get an enforcement order if it's a severe problem. Then I can try to get an enforcement order, and that's really the extent of my power, so to speak. And an enforcement order does not help with substance abuse, because yes, we can get an enforcement order, they can get their long-acting injectable, but if they're doing methamphetamines, it's going to seriously inhibit the drug from doing what it needs to be doing to help them, the medication, that is. Miscommunications between inpatient and outpatient providers. Yeah, it's a problem. So there's a good story. I had a client, she was doing some self-injurious behavior. She was not in good shape. We would send her to the hospital that her insurance covered, and the psychiatrist inpatient would change all of the medications, wouldn't talk to the outpatient psychiatrist, wouldn't try to work collaboratively, and then they would get out of the hospital, and then we'd have to start from scratch. So that's a big problem. If ever you run into anything like this, try to get the inpatient psychiatrist to work with the outpatient provider. Continuity of care is huge. With people with mental illness, if there's no continuity of care, it could mean stability to instability in a very short period of time. Okay, advocating for treatment guardianship, educate. Okay, so this is it's a little bit of a hard pill to swallow, but I've learned that it's accurate. There's going to be a lot of situations where you're in front of judges or the police or even family members, natural supports, and you have to educate them on treatment guardianship. The first time somebody told me, a lawyer from a state agency said, well, Brendan, you got to tell the judge what to do. And I was like, okay, you want me to go in front of a judge and tell them how to do this and what to do? And they said, yeah, you're the expert, tell them. And I was like, okay, let's give this a try. I'm not scared of much, but people in black robes scare me. Judges are very powerful, and they're very smart, right? And they see right through any kind of nonsense you're putting in front of them. So this was kind of a tall order for me. I've done it a few times though. And what I found out was judges that don't know the answers to these things really appreciate being educated on them. As long as we do it in a professional or mature manner, the judges want to know. So that's what I learned about it. It was difficult for me at first, but then lately at Your Honor, may I inform you about this and what might happen if we don't do this or X, Y, or Z, and educating them on the limit of treatment guardianship and the limit in time and scope. Because just because they're judges doesn't mean they know everything. And I don't know a lot, but I know a lot about this. And so that's what I do, is I try to inform the judge, educate them, and usually outcome is really good. Reaching out, seek assistance in assessing treatment guardianship through the courts, social workers, treating physicians, and hospital ombudsman. There are also, it's not listed here, but every hospital has a in-house advocate that you can ask for. So if somebody, let's say, I think a lot of people here are from Santa Fe. So if somebody is in Christus St. Vincent's, for instance, you could call and ask for a advocate through Christus, and they can help you through the process of getting a treatment guardian. Okay. I always just ask for social workers. That's what my field is in. I'm in the middle of getting my master's degree, so I feel a kinship towards social workers. So I always say, let me talk with the social worker in the emergency room. And that's how I get a lot of really good results. Understand the law. New Mexico state law that details the role and responsibility of a treatment guardian so that you can so that you can oh, I found a mistake. She rarely makes mistakes. So that you can use the information when necessary. So basically what I would like to get from that is just know your authority. Know that you can use an enforcement order if necessary. Exhaust all resources, write letters to judges and legislators if you have trouble obtaining a treatment guardian. This is more for rural areas. It's really hard to get a treatment guardian in rural areas. But going to the district court and writing letters, they do care and they will respond, especially if it's in letter form. Remember, judges are kind of like attorneys with black robes on. So, anything written down, it's black and white. It might as well be etched in stone. Okay. Lawyers take things in writing very seriously. Now, a little bit about Honor Guardianship and our team. I will have you know that all these pictures are about 10 years old. So I'm a little thinner. I've got a little bit more hair here, but that was from about 2013, I think. And this is my wife. She's our chief financial officer. She only deals with billing and all of that stuff I don't want anything to do with. This is the young woman, Kate Campbell. We hired her on. She's our chief operating officer. She's very, very bright. She's the one that made this for me. I told her what I wanted and she put it together. She's a great resource and I probably don't pay her enough. Lindsay Rutland is with us and she does all of our intake. So if there's somebody that you wanted to have a treatment guardian and you wanted to go through Honor Guardianship, this is the person that we would touch base with. She's also our quality assurance person, and she reaches out to 10% of the 500 we serve. She reaches out to 50 people every month to make sure that they're getting the appropriate treatment. And if they say no, then she sends me a letter saying, hey, this person is having a hard time with their treatment guardian. You got to fix it. And then I go and I fix it. Kimmy Jordan, I call her Queen of the South. She is the compliance officer for our company in the southern part of the state. And because every county does things differently, I'm constantly having to call Kimmy and say, hey, how are things done there in Las Cruces? And she tells me how things are done. So that's just our administrative team, by the way. I think we have right now 45 contractors in the state. And we're very, very flexible on treatment guardians because the pay it's not a full-time position. I'll just be frank. This is a position for people that want to be involved to help people with mental illness. They get paid a stipend monthly. And I do pay extra. We are a huge state, and I do pay extra for anybody that's willing to travel to see clients in rural areas. So there is a pay scale. There's the minimal pay is $70, and that's if it's within a 70-mile radius of the client. And if you have to travel outside of a 70-mile radius, then I pay $90. So a lot of times what we'll get is, hey, I'm a contractor. My son lives in Raton. So if you have any clients up there, go ahead and give them to me. We give her 7 clients in Raton. She goes up there for the weekend. She makes $630 to visit 7 clients, and then she hangs out with her son once a month. And so we have to be inventive. We have to be creative because we don't have a whole lot of capital to work with. Okay. It's just the nature of the beast. But all of these people they're very capable, and I have convinced them that working here is the right thing to do, including Mrs. Gould here. All right. For more information on our programs, please visit. You can go to honorguardianship.com. Real easy to find. Our logo is a fighting lion. It is actually a coat of arms from my family. It was a person with extreme mental illness that gave me this idea. I was going to pay for $300 to have somebody design something for me. And a person with severe mental illness, he was passed away, but he was bipolar. He had bipolar disorder. And he was telling me, you're European, look up your name. I bet you could find your coat of arms for next to nothing. And I did. 99 cents. I paid for my logo, and it's a Gould family emblem logo. Did she put it on? I told her to put it all over this thing. She didn't put it on here once. Oh, she's in so much trouble. So yeah, if you see a fighting lion on a shield, it's Honor Guardianship Services, okay? So a lot of information. I talk really fast. The reason I do is because I talk about this all the time. A lawyer from a state agency called me today, and she's like, "Tell me about treatment guardianship." I said, "Are you sure you want to talk to me about this?" An hour later, I think she was done. She was through with me. So I talk fast, but it's information that I am constantly talking about. It means a lot to me. Frankly, I think it is, how do I say this without ruffling feathers? I think it's a shame. I think that it's embarrassment of how people with mental illness are treated in this state. I'm not going to go into too much detail, but I know other people with different kinds of disabilities get they get a lot more help and services than people that have just strictly a mental illness, and it bothers me a lot. I have been doing it's going on 10 years. And so, you know, I hate seeing how people with mental illness just don't get the services they need. It bothers me quite a bit. So that being said, if anybody has any questions, now would be your time. Don't hesitate, bombard me.
Okay, Brendan, I'm going to go ahead and start. So let's say that you are currently caretaking for a family member. I mean, is it a possibility to get them enrolled in this program so then you're getting some sort of stipend for the work that you're already doing?
Well, that's a wonderful question. I'm going to stop share so I can see everybody. Is that cool?
Yes.
Okay. It's a wonderful question. So I have asked the state agency that oversees what we do whether or not we can do that. I personally do not see a conflict of interest. I think that people should be able to be the treatment guardian, especially if they're family, and they should be reimbursed for their work. But is your question more about being a contractor or being a treatment guardian plus and being paid? Or is your question more about being a treatment guardian for your family member and there not being a conflict?
It's more about being paid. I know someone who's already, working 2 jobs, taking care of their son. And, is there any relief that they could get, financially, because they're already, doing this work and advocating for their son?
So in short, I don't know. I have asked the state agency that oversees what we do, and they seem hesitant to allow me to do that. I don't see a conflict. I've voiced my concern and my wishes, but I don't think that the response I'm going to get is favorable. I think that it's going to be difficult. I think that the state agency may believe that it's a conflict of interest, but let me find out. And I'm sorry, that's the best I can do, but that's the best I can do at this time.
Okay, so I'll just follow up with one question, and then I'll let you pick the questions because I actually, for some reason, can't see everybody. But so I know you just had a training and you're looking for treatment guardians. So what kind of person are you looking for?
For me, I look at 2 different categories. I look at the professional categories, what I call it, and then I look at people that have had experience dealing with family. Now, that doesn't mean that you could be the treatment guardian for your family member through Honor Guardianship, but as you guys, I'm sure, are well aware, you have to serve and be a pseudo staff for family members that are severely mentally ill. So on a resume, I either look for education, professional background. Yes, I've been a psychologist. I'm a therapist. I'm a guardian, full plenary guardian for another company. I have been for years. Those things I set aside as an automatic shoe-in. And then I look at the other side of the spectrum. My sister is extremely mentally ill. I've taken care of her for many years. I know the ins and outs of lithium, and I know about when she has her a manic episode. I've seen it. I've dealt with it. So I kind of put the 2 into 2 different categories: real life experience and or education and professional.
Okay, great. I'm going to go ahead and read off a question from the chat. What if the individual in your family still refuses to go for treatment, so there's no mental health professional who is personally aware of the individual's state of mind? Is it still possible to get a treatment guardian for that person?
Yeah. So at that point, generally speaking, we're kind of getting into an emergency territory, right? And so if police have to be involved, if the person's committed to the hospital based on dangerousness, then that's the best time to get a treatment guardianship done. And so if you have a family member, they're hospitalized, they're committed, that's the time to call the social worker and say, my son or daughter, my sister, she can't make decisions based on the severity of her mental illness. We have to push forward with a treatment guardian. At that point, the hospital knows what direction to go, and they can petition the court. So
you said you did in a lot of the scenarios when you, because I know it's a complicated process to become a guardian or to get a guardian, right? So you mentioned if you're at the hospital, in that place you could be directed to a social worker, but how would you get in contact with someone like that if they're not, you don't have someone who's hospitalized or in a place like that?
It's tough. Frankly, it's just really hard. There's a few avenues of just some tricks of the trade. If they have a primary care physician, the primary care physician, if so inclined, could act as a qualified healthcare professional and say that they lack capacity. That's one way of doing it. What other ways? The other way that you could possibly do it is if the person is self-neglecting themselves, you could make an APS report with Adult Protective Services and try to get them involved. And that might be helpful in pushing it forward through the courts. I'm trying to think if there's any other way to do it. Oh, well, if police are involved, you can always ask for, I'm not sure how it's done exactly in Santa Fe, but you can always ask for a crisis intervention team person. It's called CIT, or you can ask for a mobile crisis team unit. And they always have, in Santa Fe, actually, the fire department has a social worker on board and a provider. And I actually got somebody hospitalized. They were sleeping outside of a donut shop in the middle of winter in Santa Fe. And we called 911. They sent the fire department out and they asked the psychologist to do an impromptu evaluation, and they got hospitalized. And the treatment guardianship was given based on her testimony. So, I mean, there's a lot of ways to go around it. But what you're asking is a problem that I have faced, and that's how I know about all these other alternative ways to go. But if you don't have a qualified healthcare professional to weigh in on the capacity, and the person that you're trying to help doesn't have a psychiatrist, it can be very tough.
Thank you.
Wish I had a better answer for that, but that's
that's okay. That was a good answer.
The other thing is ACT teams. I'm not sure if in Santa Fe, I'm not that familiar with it up there, but in Albuquerque, there's a couple, and in Las Cruces, there's quite a few. But ACT teams are teams with social workers, therapists, and psychiatrists that come out to see the client, the patient, as opposed to them having to go into the hospital. So I'm just not sure on the answer there, but that would be something that I would look up if I was having trouble finding somebody to be the provider for my loved one.
Okay, great. So I'll let you, if you see anyone else with a question, normally I pick them out, but I can't see a thing. So.
Oh, hi Tina.
So Brendan, I'll jump in. This is Tina.
Okay, great.
Tina Schuler. Hi, Jessica.
Hi, Tina.
I just first of all want to applaud you and thank you. Thank you so much for doing this work. I think anyone who's hospitalized, anyone who has severe illness of any kind can use advocates. And so oftentimes family don't understand what the patient needs, and the patient isn't able to communicate. And I don't care if it's mental or not, but mental makes it so much worse. So having said that, thank you. Mike, I have a couple of questions I'm trying to understand. Are you being paid directly by the state, or do families pay you to serve as a role? I can't tell. And also, where are these requests coming from? More from the state, from patients who are wards of the state, or is it more coming from family members? I don't understand how the influx is coming into you.
Sure. Good question. So I have a few different contracts with different entities in the state. So I have one with the corrections, which talk about interesting. So I go to the prisons once a month. And so I have a contract specifically with them. And then I have a contract with the DDC, which is better known as the Office of Guardianship. And I serve the bulk of the people I serve are through that agency. But private pay is generally not something I don't do a lot of private pay, but that's what it's called. And that would be family that are looking for services. What I generally try to do as far as private pay is concerned is I always put forth the idea of paying me to consult, because a consultant, when it comes to family, that goes a long way, because they just don't know the resources. They don't know how to get the treatment. They don't know who to call when there's an emergency. They don't know these things. So I try to do, and I, I don't know how to say this in any other way, but I try to look to see, can this person afford to pay to consult with me? You know what I mean? If they can't afford it, I just do it. Well, I got to sleep at night, So if they can't afford it, then I just do what I call a brief consultation, and I just give a list of resources and ideas and call this doctor. I know there's openings at this hospital or that hospital for psychiatrists right now, that kind of thing. But I've taken on private pay for full plenary guardianship, but I can't think of a time when I did a private pay treatment guardianship.
Okay. Thanks. And the only other thing I was going to add to it is I can just say from my perspective as a New Mexican for, gosh, I don't even know how many years now, 40 something years. I can speak to the very real stigma in New Mexico between just providers of mental versus physical illness, and whether whether they talk to each other, or whether go forward with a disability, don't say anything about the mental side, just talk about the physical issues. And when you're in a hospital, how difficult it is to communicate, and that whole issue that you said between inpatient and outpatient care, that exists on both sides of the house. It's not just a mental issue. So there's so many commonalities. That's all I'm saying. There's such a need for advocacy and for education. This is awesome. Thank you.
Oh, well, you're welcome. And I think that a lot of times, and I think we're headed in this direction, but I'm not sure that the overall system is really ready for this, but the two relate to one another. I mean, if you're severely mentally ill, the chances of you having physical illnesses it's great. And the vice versa. There are actual physical illnesses that will cause you to have anxiety attacks, and they're severe, but it's actually a physical illness that's causing it. The two are combined. I mean, they're intertwined, and there's always this black and white separation, and I'm not really sure why, especially with medications that you're taking, because they have side effects. If you're going to be taking Clozaril, you have to get a blood draw done every 2 weeks because the medication affects you physically. So I'm not really sure why there's that huge disconnect.
Well,
but
if you understand the education system, sorry to interrupt, if you understand the education system, there's so much information that our medical professionals have become specialized, obviously. And as they specialize, they silo. And as they silo, I had to learn as a patient who's had like 10 different specialists in my medical history. They don't like to talk to each other, and they don't understand systems outside their body of knowledge. And so they won't talk about medications that go outside their specialty. And it becomes very difficult then, as one patient who's struggling with all these diagnoses, how do you bring it to the table and say, okay, my pulmonologist only wants to hear about XYZ. My psychiatrist only wants to hear about, CDF. My, it's ridiculous. And I understand it's complicated, and that's Western medicine for you. And the fact that we have all these labels and diagnoses, and these are the meds that go with each one. And our poor pharmacists then are stuck with going, oh, hey, this one interacts with this one, interacts with this one. They know the most on the med side of the house. So I feel for you, Brendan, but I'm just saying that's the reality of where we sit.
Yeah, I call it the referral system. You have to get a referral to see a specialist for this and for that. The nice thing, though, about having a background and getting an education in social work is that you see the person in the environment, and you start to see how the whole system affects the one person. And so of course I'm biased, but I think that's kind of the nice part around social work, is you see how everything in the environment affects the person, whether it be medical, psychiatric, where they live. Did their parents just get divorced? Did their mother just die? I mean, because you're going to have acute issues if you have a close family member pass away. It doesn't mean that you're going to be chronically severely depressed. You may just need some help for now. And that happens pretty rarely in my business, our business, because usually by the time we get tapped for help is because it's chronic. But every great once in a while, something acute comes along and we can get rid of treatment guardianship. We've helped them through the hard part and got them hooked up with therapy and things like that. But that's pretty rare.
Thank you.
Any other questions? Go ahead, Cameron.
Oh, great. And thanks, Brendan. I really appreciate the presentation. I think I learned a lot about the process of involving a treatment guardian. And my question is, does the treatment guardian then typically spend an equal amount of time, speaking with the physician who's recommending a course of treatment and, picking the option that's most suitable for the patient, or more working with the patient saying, I understand that the physician's given you, 3 options, and which one do you want? So we can go back to the physician and tell them how to proceed. I'm just sort of curious on a nuts and bolts, level, what it looks like to be a treatment guardian, sort of filling that gap, I guess.
I would say it's equal parts, but I would also say, because we're professional treatment guardians, there's also the component of family or I call them collateral contacts. So I had one guy, he didn't have anybody, but he loved his next door neighbor, who was an elderly woman, and she kind of looked after him a little bit. And I would spend as much time talking to her as I would my client, because he was actively symptomatic. Okay. And so I wasn't getting a lot of straight answers. I shouldn't say it like that, but you know what I mean. I wasn't getting answers that were helpful, right? Because he was actively psychotic. So I would go to her and I'd say, well, how's he doing this? Or, do you see him sleeping at all? And so I would spend a lot of time with her. So I would say equal parts collateral contacts and client, because we need an outside perspective and somebody else that can weigh in on what's going on. So yeah, I would think of it more like that: client, collateral contact. And that's just to give us a basis of understanding of what's happening, because we can't always be there, right? So this woman, her name was Tina. I'd knock on her door every time I went to see my client. I'd say, hey, how's he doing? Anything I need to know about? He says he's doing great. He's taking his medications. He gave me autonomy and to speak to you, authority to speak to you, so what can you tell me? And I usually find out a lot more from that collateral contact, because the person is suffering, either symptomatic at the time. So getting logistical information, demographic information from the patient is going to be difficult because they're suffering.
Great, thank you. That helps a lot. Great.
Any other questions?
Okay, if there aren't any other questions, I have a final question,
Okay.
Brendan. So the NAMI National just started this podcast and called, I think it's Hope Starts With Us. And at the end of it, they always ask the same question. And I'm going to ask you a variation, which is just, what gives you hope for the future of mental health in New Mexico?
Boy, that's a tough one. Can I, in New Mexico in particular?
I asked in particular just because I'm curious about New Mexico in particular, but it doesn't have to be that. You can
All right,
answer however you want.
I have two answers then. I have one for New Mexico and I have one just in general. So in New Mexico, in Las Cruces, there's a program called AOT. It's called Assistive Outpatient Treatment. And they put a judge in charge of it, and people that suffer chronically, that are maybe having trouble with the law, homelessness, things like that, you can apply to get them into this program. And what they do is the judge meets with client's attorney, psychiatrist, treatment guardian once every quarter. And like, remember what I was saying earlier about, you know, I call it the black robe effect. You know, there's one for doctors with the white robe, right? Or, you know, the white coat effect. I call it the black robe effect. And you get in front of a judge, these people have a lot of authority and they're very, very smart. So when you have an AOT program like that, and you have a judge overseeing what's going on, there are safety issues, things like that. The judge has a lot of teeth and they can really help. We had the AOT program in Bernalillo County. I don't know what happened, but it shut down, but it's coming back up. And so I would say what gives me hope is that AOT program is going to start back up in Bernalillo County. There's going to be a judge. Her name is Judge Brickhouse, and she's very smart, very good advocate, and cares about the people that she oversees, and they're in her courtroom. So I have a lot of hope for Bernalillo County in New Mexico, because that AOT program is gonna be coming back pretty soon. Second part of that answer, and I'm long-winded. You can't talk to me about treatment guardianship because, like, I'm seeing it 7:01, and I'm like, but there's so much more to say.
Yeah, go ahead.
The other one is, in my family, our favorite show is called Bob's Burgers. Okay, it's a really good show if you guys get a chance to check it out. But in one of the episodes I've seen recently, there's this kind of bully across the street. He's the guy that owns an Italian restaurant, and he starts calling the main character crazy. And he's just like, you're out of your mind, you're psychotic, you're crazy, right? And one of the secondary characters, who is one of the guys that gets bullied all the time, stands up and he says, no, you can't call him that. It's not right. You're talking about severe illnesses, and you really need to be more thoughtful before you call somebody psychotic. And it was just like out of the blue. This is a comedy. Okay. And this bullied guy's like, you know what? That's not appropriate. You don't need to do that. You don't need to call him those things. And I was like, wow. So in other words, it's starting to get into the mainstream a little bit. And I think when that happens, we start to look at the stigma going away. Okay. You know, oh, she's crazy. She's crazy. You know, that's just this phrase we hear all the time. But when you work in this field, you're like, no, she's not. She's upset, and she might be a little irrational, but she's not mentally ill. So, you know, I like that it's coming into the mainstream, and people are starting to think of these sayings that get used all the time without any thought, that people are actually starting to think about it and not maybe use those terms anymore.
Nice. That's wonderful. That is good to hear. And it is a good sign, but it's also just hearing that those hopeful things reflected back. It always feels good. So thank you so much. You know, I'll let Tina go on.
I'm sorry. I wanted to jump in and just say, and Brendan, you've given me hope for the future of New Mexico, mental illness in New Mexico. So thank you for that. Thank you.
You're welcome. And you know, it's NAMI is such a great organization. When Jessica's mom is heavily involved, I think it might have been her initial idea to ask me to do this. I thought, oh wow, I get to team up with you guys, because it's a grassroots kind of deal, right? I mean, so you guys aren't getting, people that are involved in NAMI are doing it because they care about it. And it's important because, there's not this large pot of money. It's more of a willpower, we care type organization. And so, any way that I can help with NAMI, please give me a call. I'm not a rich man, but I can be pretty convincing. If you need me to convince somebody of something, give me a call.
And we do have your contact information, so I'm sure we'll be using that very liberally, and we'll send out the recording with all that information next week. But thank you so much. Yeah, it is. We really appreciate the work you're doing, and then taking the time to come explain everything. I think you did an excellent job.
Thank you. And I feel bad about one thing, and that is I just don't have an answer. I really want family to be able to get paid for their services, but I just don't have an answer. And so that was the one question you asked me, and I just haven't been able to get a black and white response. So I'm going to continue to push on that and work on it. And hopefully if I ever come back, or if I'll write you, Jessica, and just say, look, I found this out. You can be a treatment guardian with us and get this stipend. Hopefully one day I'll be able to give you that good news. But right now I have not gotten a real clear answer on that.
Can I just add, we used to be foster parents, and this is sounding an awful lot like the foster care system. And I know it's taken a long time for New Mexico to figure out how to give stipends to family members who have been involved with dependent care situations. So I don't know if it seems like this should segue into and track with whatever's happening in the foster care system.
Well, I named the company Honor Guardianship.
Disabled individuals.
Right.
Yeah,
Right. Yeah, I knew exactly what you were talking about. We call the company Honor Guardianship, and it kind of puts me in a position to always be honorable. Should have named it Shady Guardianship or something. But I'm always trying to do the honorable thing, and I'm pretty good at sniffing out conflict of interest. And I just don't see one. I don't see it. And, but I'm not a lawyer. And so there may be some kind of nuance or something that I'm just not aware of, but I just don't see a conflict. So I'm going to keep pushing on it. Because not only, and I'm long-winded, I'm sorry, but not only would it help get a little bit of money for the family member, but what it also does is makes you a part of Honor Guardianship, right? So when we have quarterly meetings updating you on resources, or we have quarterly meetings about, hey, we messed up on this, we just said something wrong, or, it makes you guys privy to what's going on in the community, because you're going to be invited to those quarterly meetings. And so, it's more than just the $70 a month stipend. It's part of a larger community.
Well, okay. Can I jump in with one last question, Jessica? So what about volunteers?
So pro bono, I actually just got one today, and I am working on that.
Well, for you be pro bono, but what about family members? Like you said, to be involved. Okay, that's what you mean. Thank you.
It's not a family member. It's actually a concerned person in the community, but they're an attorney, and they don't want to receive any payment. So I had to kind of go through the rigmarole of how do I get this person to be part of Honor Guardianship but not receive payment. And so I just did that for the first time today. So I'm trailblazing that, and hopefully I will know more in the future, but I think it's going to work out. They just don't sign a contract. I'm not able to get them liability insurance, things like that, but they're going to have an Honor Guardianship email, and they're going to be invited to quarterly meetings.
Nice. Okay.
One thing at a time. But I'm on board with you. I think that's a great idea too. But again, before this ends, very appreciative of what NAMI does. I hold what you guys do in such a high esteem, and just keep up the fight. I don't like to use that word very often, but it's a fight.
Yeah, and same to you, Brendan. And again, thank you so much.